Manager for PCDC, Primary Care Development Corporation.
And this is Mazdak Mazari, also from the Primary Care Development Corporation. I'm a project manager here, and I'm a co-lead on this project. And our role is really to support in terms of the performance improvement to help bolster your clinical measures.
Great, thank you. And I am Ms. David Lewis. Are you able to hear us now? Let's see. Not sure. And sorry, who's there from Buffalo?
You have Dr. Fan. I'm serving as the clinical representative for this project.
Great. And is anyone else joining you?
Dr. Ansari, the CEO, has a previously scheduled meeting. I think she may try to join us a little later. And Beverly Lewis should be on the line.
Yeah, and I see that she's joined us on the web part of the webinar. Is she in the physical building with you, or is she at another location?
I'm actually in a different location, yeah.
She's
in a separate location.
Okay, I'm going to send her the call-in information right now, and then hopefully she'll be able to join us on the phone.
Okay.
And I'm not seeing her join us right now, so let me give her a call. But let's get started, and then I will give her a call with the call. Oh, there she is. Ms. David Lewis, is that you?
Yes, it's me.
Oh, good, great. All right. Sorry for the difficulty. Could you just introduce yourself and let us know what role you play at the health center there?
My name is Beverly David Lewis. I'm the coordinator of the HIV grant here, and I'm also the head of the social work department.
Great. Joining the call from our end is myself, Jared Casanidi, and Stefan Perez, our clinical specialist. And then we also have Sarah Blust, I believe, and Mazdak Mazari from our performance improvement team.
Yep, Sarah Blust. Hello. Hi there.
Hi
so
there.
I did want to. So I'm going to jump right into it. Did want to. Did want to talk a little bit about the purpose of the call, and then we're going to ask you to talk a little bit about why you joined the project and what you hope to get out of it. Then we'll go over the clinical aspects of the assessment that you sent us today. And once that's done, and we are also going to go over the HIV training package. And then we will go over the performance improvement aspects of the assessment. And we hope that the CEO, Dr. Ansari, will be able to join us for that. And then we will have just a small period for discussion, answer any questions you might have, and then we will talk about the next steps in the project.
Okay.
So the purpose of the call today is just to allow us to get to know you better, to get to know the services you provide, the the services you're hoping to add to your clinic, and also just to get to know who you guys are a little bit on a more personal basis. And this call is in lieu of an on-site visit. That's the ideal, is to pay you guys a visit, but that's not always possible. So we are excited to meet you later in the month at the community meeting.
Okay.
So I'd like to ask you just to tell us more about your health center, give us some background, the reason for your application, and what you hope to achieve.
You're talking to Beverly, correct?
Whoever there would like to lead from your end. I think if one of you has more to say in terms of the background, then by all means, please cover that section. And then if one of you wants to discuss why you applied, then you can shift it over to the other.
Okay, well, I'll take the lead, Beverly. This is Dr. Fan, by the way, Beverly.
Hi, Dr. Fan.
Hi. The Community Health Center, as you all know, is a federally qualified health center that was established in the early 90s. And I came on board with the Community Health Center as a member of their board. And my background, by the way, is I'm a family practitioner, but I'm also a healthcare administrator. And what I noticed when I came on board with the Community Health Center in 2005 is that they were doing very little HIV testing. I had them pull some data, and in 2005, they performed a total of 5 HIV tests on site for the whole year. And I don't know how much you all know about Buffalo, particularly Buffalo's east side. It is a very medically underserved community with a very high unemployment rate. At any given time, it can be 60%. Very high high school dropout rate, and Buffalo has a significant, compared to New York City, Buffalo has a significant problem with HIV. And so what we were noticing is that, particularly within the community that the Community Health Center serves, that really was the epicenter of Buffalo's HIV epidemic. And so with that information, it was a serious disservice to be only performing 5 HIV tests in 1 year. So Dr. Ansari came on board about the same time that I did, and we made the commitment to really increase the number of HIV tests that we would perform. And so in the first 6 months of Dr. Ansari and I working together on, improving HIV testing, I think we got somewhere like 500 people tested in a matter of 6 months. And really since that time, we've just continuously expanded HIV testing to the point that today we're almost doing it we're offering it as a routine test. So we've really come a long way in terms of HIV and AIDS. Is there anything else in particular that you all would like to know about the Community Health Center in terms of demographics?
Yeah. Hi, Dr. Fan. This is Stefan Perez. I switched seats with Jarrett here.
Okay.
That's a really, really inspiring story. I'm wondering if maybe you could also share with us, like you said, a little bit of demographics. But before you do, would you mind just briefly kind of sharing how you did that rapid scale up in only 6 months?
Well, what we did was we really, on site, we had all of our medical assistants. What we did was we made sure that they were all certified by New York State as HIV quote-unquote counselors. And then what we did was, I also must add that at the time that I was at the Community Health Center, I was also doing NIH work on HIV testing. So I already had a series of community-based testing initiatives going on. And so what I did was I just brought the Community Health Center into that, and we did very intense social marketing. We went out into communities. The Community Health Center participated. They sent out their medical assistants to community-based events. We went into the projects that were notorious for having serious serious numbers of people addicted to crack.
Right.
We also did internal testing, so like all of the days of national observance, we would roll out for the entire month. So, for example, February, National Black HIV Testing. For that whole entire month, we tested, and we would give the employees incentives. If you get 200 people tested this month, then we'll reward you with something.
Wow, yeah.
Yeah. And the thing about it is that, unfortunately, what I noticed is that the community, we had actual testing kits on site that were expiring. The dates of expiration were due because they were not being used. So really, what we did was we really put forth a lot of effort towards educating our providers and other support staff, getting them to buy into this whole concept of, HIV testing should be offered as a routine test, and that required a lot of education. We had people come in from the pharmaceutical industry giving luncheonings about HIV and what the epidemic in Buffalo looked like, because a lot of people, and the staff at the Community Health Center weren't unique, because even at the University of Buffalo, where I also had an appointment in conjunction with my work at the Community Health Center, even the scientists there were unaware of Buffalo's, HIV problem. So it really, HIV in Buffalo for a very long time was what I like to call a silent epidemic. So I don't know if I've answered your question fully.
No, yeah, that's great. Thank you. If you wouldn't mind sharing a little bit about your demographics and
Sure.
And then also a little bit about just a little bit about the staffing at your clinic.
Okay. Well, the Community Health Center of Buffalo's main target population, because of its location, are African Americans. And the last time I checked, and Beverly, you might be able to chime in, they were serving about a little over 90% of the community service is African American. We get a lot of immigrants from Africa. Buffalo offers some kind of immigrant asylum, so as a result, we get a lot of immigrants from a lot of the sub-Saharan countries in Africa, which have been hard hit, as you all know, by HIV. Also, given Buffalo's close proximity to the Canadian border, we get a lot of immigrants over from Canada, a lot of Russians. So we do have a percentage of patients that come from out of the U.S. We also, I think significantly, about 80% of the patient population is Medicaid or self-pay, uninsured. I think, and Beverly, you may know the more accurate numbers, about 15% of the patient population is private insurance. Is that about right, Beverly?
Yes, that's correct.
And a lot of our patients are, they may have completed high school, but Buffalo as a whole has a really high, especially on the east side of Buffalo, a very high dropout rate, where I think it was estimated only 25% of seniors were graduating from high school.
Wow.
And the average median income, the last time I looked at the census, was about $15,000.
Wow.
So we're talking serious poverty. And, Buffalo, ironically, is the second largest city outside of New York City, but it only has about 290,000 people in the population. And so when you look at their HIV numbers compared, to New York City, they really have a very high rate. When you look at it per 100,000 of the population. So, Beverly, would you like to add anything to that demographic description?
Nope, I think you covered it all pretty well. Other than the fact, well, it's all covered pretty well, but because Buffalo is definitely a melting pot, we probably represent, the Community Health Center probably represents 13 to 24 different nationalities.
Wow.
So we do reflect the community itself. So Buffalo is somewhat sectioned off into a certain parts of town will be this demographic versus this demographic. But we've been able to cross those lines and actually recruit and retain patients from those areas based on the services that we provide.
Yeah, especially in the last 5 years, especially as the immigrant population has increased. So now, like she said, the patient population really is becoming more diverse, and it represents more of a true melting pot. You know, and so when I say African Americans, I guess I should really say Black, because you're going to have, you know, Black people from all over the diaspora included in those numbers that I quoted to you. So.
Awesome.
And
well, thank you for that.
Yeah, and we're probably about 10 minutes by car from, we have a refugee site and living facility, probably within 10 to 15 minutes of the facility.
Wow.
So we're very much located near them, so that if service is needed, they could actually get to us for service.
That's fantastic. Great, thank you. Thank you for sharing that. And if you don't mind, really quickly, we're going to move forward here to the clinical. But would you also mind just sharing what you hope to achieve through participating in this project?
Sure. I think that right now the Community Health Center of Buffalo is doing a really, really good job with HIV testing and screening and linking people up with care, outside sources of care. What I would like to see come out of this project is that we get to a point where we can actually provide HIV primary care within our facility, as opposed to the common practice now, which is to refer out. So the providers tend to, if they find a new HIV positive person or someone comes in who already knew their status, they'll refer them out because they're not comfortable providing HIV medical management. So I'd love to see the providers begin to provide HIV medical management on site.
Great. Well, that's our job. So hopefully we can accomplish that together. I think we can. Great. So I just want to confirm that everybody can see my screen. Are you both able to see my screen okay?
Yes.
Okay, great. So we're going to go ahead and move into the clinical training needs assessment, and we're going to just review here, take a few minutes and review your responses and walk through it together. And I'll ask some questions on where I'd like some clarification if possible. And Dr. Fan, it looks like you completed this, so thank you very much for taking the time to do that, and you did a great job.
Oh, thank you. I didn't do it all by myself. Beverly.
Okay. Thank you, Beverly.
You're welcome. I tried.
Thank you.
I was really pushing for that 12 o'clock.
I know. You did great. You did great. Great.
Thank you for the 20 minutes. I appreciate it.
You're welcome. So it looks like you reported here that you have 3 HIV patients on your census according to your UDS data. Is that accurate, would you say?
Yes.
Oh, okay. And it looks like, I'm sorry?
That information was pulled from our USD report for last year.
Okay, gotcha. Perfect. And it looks like you've noted here that you have a special interest with working with immigrant populations and recently incarcerated, which you definitely shared a lot about, as well as the substance use. And I also see that you have a specific interest in working with women. Is that something that you all are faced with a lot? Are women a heavy portion of your patient population there?
Yes.
Okay. And do you come across a need for HIV care or intervention with your patients, your women patients?
Yes. I think that given the environment that a lot of our patients come from, they're at very high risk for new HIV infection. And you know, this is not unique. You know, it's just like what we see in the national data. So, yeah, we focus
Great.
a lot on women.
Great. Well, we definitely have, in addition to our foundation curriculum, which is, you know, sort of some of your basic prevention and testing topics, we also have a specific women-focused portion of the curriculum for providers and nurses, so that they can learn about specific women-related interventions around HIV care and prevention pieces.
Okay.
So, okay, great. So I'm going to move to the next page here, and this is talking about your care team. And it looks like you've indicated a Dr. Jamal, who's a dentist, as one of your providers. Do you have other providers that you're planning on that are planning on participating in the HIV training?
Yes, we have an MD, Dr. Dowell. He actually has a little bit of HIV experience. He came to us from New York City, where apparently he did a lot of HIV-related management. But he's really one of the doctors that's willing to try to manage naive or first-line ARV patients. But he needs a lot of support, yeah.
Okay. Totally understandable.
Yeah, I didn't get them all in there yet. I will.
That's okay.
We have a nurse practitioner who has expressed an interest in learning more about HIV management in the primary care setting, as well as a PA. So.
Great. And Beverly, I'm wondering if it might be possible for sometime today or tomorrow for you to send me a list of the remaining care team members, just so that we can sort of put them into our application here and we have a record of them.
Yep, I certainly will.
Okay, that'd be great. And do you have other registered nurses or LPNs, medical assistants that you've identified as well?
Yes.
Yes.
Okay, great. So if you could send me those two, and we'll go ahead and send you the assessment, the self-assessment forms for your providers today. And I'll talk a little bit more about that, but we'll make sure that we get you all the ones that you need for all the providers that you might engage.
Okay.
So moving forward to the HIV care capacity page, this is really, we'll talk a little bit more about this in a few minutes, but these are really how we sort of stage our sites based on how they deliver HIV care and also the level at which that care is delivered. So it looks like you all have noted here that you are in the external care model, which is providing HIV testing, but no medical management for patients with positive results. And based off of what you told me, I think that's really accurate. So great job with that. And also on the next page, we're talking about the clinical stages. And again, this is the sort of level of care that's provided. And again, you've stated that sort of as a practice as a whole, you really are referring patients out. You're providing testing, but referring patients out. So that is perfect as well. I think you're right in that foundation stage.
Okay.
Okay, great. And briefly, we'll just go through the mentorship and clinical consultation. And I just want to confirm that you haven't had any HIV-related clinical trainings or consultations in the past year.
Right. No, we haven't.
Okay. Okay. And Ann Januski, is she? I see that she's from Gilead.
Yeah, she's from Gilead, and in the past, she has had sessions for our providers where she would have an expert come in, an HIV specialist come in, and talk about treatment and care.
Okay, great. So is she a clinician, or she's just your sort of link to
she's the liaison base? Yeah, she's the
great.
liaison who provides. She works with Gilead. She actually works for Gilead, and she provides us with speakers from their speakers bureau.
Fantastic. Okay, great. Okay, excellent. So we'll move towards the next page here. And it looks like you do have some regularly scheduled provider meetings on Wednesday mornings, it looks like, every month. And you have indicated that you might be willing to use some of this time to dedicate to group training.
Sure.
How long are those meetings typically that you have?
They usually last well, sometimes they can last the entire morning depending on what's on the agenda, but
okay.
Usually a minimum of 2 hours, but we can always extend it for the entire morning.
Okay, great. And the only reason that I ask is because, you know, we know, and the clinical team definitely here, as all of us providers know, those provider meetings can be really jam-packed with, you know, all of the business that has to be done for the health center. And so we just want to make sure that that's a realistic option for you all. And it sounds like, you know, they're kind of flexible.
Especially if we have advance notice.
Yeah, and what we're going to talk about when you all come down to the community meeting is get into a little more about training plan development, and we'll definitely make sure that we're sensitive to the fact that the health centers need as much advance notice as possible. So definitely take that into consideration. And it looks like on a weekly basis, you're thinking maybe for group training activities under an hour a week, and that's definitely understandable given a lot of time constraints. Do you have any indication? I know you said that there's a couple, an NP and a PA and another doc who has some interest. Any idea about how much time they might be willing to devote on their own sort of self-study through the materials?
I don't know right now, but I can find out.
Okay, and no problem. And we'll give you a better overview of what exactly the training entails, so that you can take that forward with them for sure. Okay, great. And you have down here that time management is a constant challenge. And gosh, we've never heard that before. Time is never an issue for anybody. So yeah, we're definitely aware of the time constraints, and it sounds like you guys definitely have a high volume of patients. So we'll definitely help you figure out creative ways to take that into consideration as we move forward with your training.
Thank you.
With that, I'm going to move into a quick review of the HIV training overall. So this will just kind of help give you sort of a 360 view of the training and the training package. And just as a note for you both, when you and your team, whoever's coming to the community meeting in April, we're going to delve a lot deeper into this so that the learning leaders will have a very good idea of what the training is going to entail for you and your team. So this is just going to be a brief overview that will move into the next phase of the assessment process here.
Okay.
So this
Dr.
is
Ansari has joined us already.
I'm sorry?
Dr. Ansari has joined us.
Oh, hi, Dr. Ansari.
Hi, everybody.
Hi, Dr. A.
Do you want to just briefly introduce yourself and give us a quick overview of your role in the health center?
I'm the CEO. I've been here 70, and we have just actually moved into the site we're in right now. So we have gone from, within the last couple of years, we've gone from let me start from 06 when I started. We've gone from 6,000 to 13,000 patients. So we just have a new site that we just moved into, that we went from 18,000 square feet to 66,000, which is our main site, and we just opened up a new site in Niagara Falls, which is our other county.
Oh, wow.
A year and a half ago, and the reason I'm late is because I'm coming from Lockport, which is the east side of east end of Niagara County, to open up another site.
Wow.
So,
okay.
view of our growth.
Yeah. No. Definitely. You guys have a lot going on over there. That's great.
Yes.
Great. Well, welcome.
We're really excited about the opportunity, though. We're really excited about the opportunity. I don't think we do enough, particularly for our needs and what we have in both counties on HIV.
Great. Yeah. Dr. Fan and Beverly were just sharing a lot about what's going on up there in Buffalo. So thank you. And we're glad you're joining us. We're just going to begin to go over the a bit of a 360 view of the HIV training and sort of what's going to be entailed. And I was just saying that in April at the meeting, in a couple of weeks, we'll go over this in a lot more detail. So this is going to just kind of be a quick run-through.
Great.
So we'll talk a little bit about the roles and responsibilities of everyone involved in the training process, and a little bit about what we call the HIV community care continuum, which is our model for service integration. And then we'll talk a little bit about an overview of the HIV training package as well. So our roles as the AETC team here is really to provide guidance for you around developing the clinical learning and training. We're going to help conduct site evaluations, which is the purpose of this call, and then some individual assessment tools, which we'll be talking about in a little bit, that will help facilitate some more structured training. And then we're going to provide assistance with developing the training plans. So again, so that you have a lot of advance notice about what your training goals are and when those training events will take place, and also to help increase the capacity in the right way with your staff. And then we're going to coordinate all of the various mentors, the other AETC staff that's going to be involved, especially with our practice transformation team who's on the phone with us today, and our training, other training opportunities that may come up in the future. The clinical learning leader, who in this case is Dr. Fan, your role will be definitely to serve as a liaison between your health center and your care team members who are participating in the training and our team here. And really, you'll be the one who's sort of, with our assistance, developing and overseeing the clinical training plans with the assistance of the clinical team here at the AETC. And then, of course, you and your leadership team there will help to define a schedule for training, and you can communicate with us at any time around any of your needs or training needs at the health center as well.
Okay.
And the members of the care team, and actually I have one more job for you, Dr. Fan, I apologize. You will also be responsible for sort of being the gatekeeper when it comes to the evaluation process, because as you all know, as part of a federally qualified federally funded anything, there's a big evaluation and monitoring component that goes along with the project. And when it comes to the individual evaluations for training and mentorship events and things like that, we really ask the learning leader to help us sort of make sure that everything gets filled out and done and returned and everything like that.
Okay.
So the members of the care team, these are going to be your actual clinicians who are engaging in the training. They're really going to be participating in those training opportunities, and that's going to be the main component of their roles and responsibilities. Again, individual training will take place on their own. They'll have to determine that. If there's any time during the workday, that will have to be worked out with their leadership team. But of course, if they choose to do it outside or on their own leisure time, then that's something that they will need to sort of work out and suss out for themselves. They'll also be responsible for doing evaluations of the training and completing a monitoring framework that will allow them to monitor their process as they move through the training package, and we'll talk a little bit more about that.
Okay.
So what is our community care continuum? Well, really it's a framework for integration. We already talked a little bit about the stages of care, and you both did a great job in determining that your stage is a foundation stage, where you're really doing HIV testing on site, but really no medical management for the patient. As you can see, the stages sort of go up from there in terms of skill set. And what I'm hearing you say is that you are interested in moving to become a facility where you can provide, ongoing primary care to HIV-positive patients who are maybe ARV naive or maybe on first-line therapy, but you're definitely able to manage, some of the antiretrovirals and some of the common complaints and issues that come along with HIV infection. And that's those are what we call our stage 1 providers, or stage 1 sites. And the goal of the program is, after completing this training, you will be able to classify yourself as a stage 1 site. And that sounds like it's kind of right within your goals there as a health center.
Right.
And then external, and then these are our integration models, which are kind of determine how you deliver that care. And again, you chose external HIV care, which I think is right on. Again, there's HIV testing, but actual care is not really, primary care is not really being delivered on site. We would then want to move you up to collaborative care, where you have HIV care with a primary care, within your primary care practice, with extensive collaboration and consultation from a clinical mentor. So part of what we're going to help you do is really identify those clinical mentors and clinical connections in your area, so that this can be an ongoing experience for you once the project is over. And so really this provides us with a stepwise approach, and as you can see in front of you, the goal is to move one step up in the model. And the training really takes place through what we're calling the HIV training package. And it's a set of learning resources and methods that you all can use and your care team can use to build and expand on-site HIV care. And really, we hope that this becomes an efficient, realistic, and replicable distance learning model to help you increase that capacity. So the training approach is assessment-based, including the assessment that you just filled out, in addition to the self-assessment that we'll talk about. It's very self-directed. There's a couple of different types, individual and group training available. And it's very flexible. There's a lot of ways to access. One of the main way really is to access it online through what we call a virtual learning lab. And it is password protected, but it houses all of the entire HIV training package, including webinars, reading materials, CME opportunities. So it's all one-stop shop.
Okay, great.
And we really hope that the content is dynamic. And as you may or may not know, we recently launched the entire HIV training package all the way up through our stage 3 providers, who are really HIV specialists. And of course, about 3 weeks after we launched it, DHHS changed the guidelines on us. So we're going to have to go back. But our goal is really to to really keep it updated so that providers have really up to the minute very relevant information at their disposal. And it is broken up by care team member, by clinician. So we have a special curriculum for prescribers. We have a special curriculum for registered nurses. We have a special curriculum for LPNs and medical assistants. And we have a special curriculum for what we're calling other care team members, but these would be like other support staff or a social work team that you may have, or adherence counseling team that you may have. Anybody really who would like to participate. We have what we call a foundational curriculum, which provides a really nice broad overview of HIV and topics like prevention. Okay. Each curriculum menu has a set of core and supplemental resources. Our core resources are really the DHHS guidelines and the HRSA guide for HIV clinical care. Also, our webinar series is part of our core resources. Each curriculum menu and learning proficiency has a supplemental resources. This is where you will find your CME activities, other presentations, point of care resources, patient education materials, all of those things that are available. So the curriculum menu are broken up, again, by clinician, and they're also broken out into stages. So your prescribers will have a stage 1 curriculum at their disposal, since that's where we want to move them. We want to move them to stage 1. So we ask that they work through the stage 1 curriculum menu for providers. And each curriculum menu then has a set of learning proficiencies, and these are learning proficiencies, or topics, if you will, that are related to HIV care that we feel are necessary for a stage 1 provider to know if they really plan to provide solid HIV primary care. And it includes things like initiating antiretrovirals, ordering lab tests for the newly diagnosed patient, interpretation of lab tests, management of side effects, immunizations for the HIV positive patient. So it really is a good foundation for stage 1 providers. And each one of those topics are what we call learning proficiencies. And each learning proficiency is where you will find the core and supplemental resources. And all of those are within the curriculum menu. And I'm going to move to an example of a learning proficiency here. And this is in curriculum menu. This is in the provider stage 1 curriculum menu. And as you can see, this is the first proficiency that's available, and it's diagnosed and managed acute retroviral syndrome. And as you can see, there's a set of core resources there. All of the resources are PDF'd, so the provider just has to go into the virtual learning lab, find this proficiency, click on it, and all of the information that they need to complete the proficiency is right there in front of them. They don't have to dig through any books. They don't have to go searching online. They can just click on the link, and it's all right there. So it's a very, very nice platform for them to use. We also are going to give you a copy in hard copy, because we know that not everybody, likes to be on the computer 24/7. So that will be available for you to keep in your office as well as a hard copy binder. And this is the Word version of the curriculum menu, and then we also have a Excel version of the curriculum menu. Both of these, as they are right now, are downloadable to your desktop. So you can actually download it once and just keep it on your desktop. You don't have to keep going back into the virtual learning lab if you choose not to. The next piece is the monitoring framework, and Dr. Fan, this is what I was referring to, that the individual learner, the individual care team member will sort of use to keep track of their own learning. So if they're doing, 2 or 3 proficiencies at home on the weekend, we ask that they use this to keep track of which ones they're completing.
Okay.
And it gives them a set of 5 indicators to kind of keep track of, and this is actually exactly what it looks like. And it's just the proficiency down the left, and it gives them 5 boxes to check regarding each proficiency. So if they've opened it and reviewed it, they can check that box. Okay. If they've discussed it, and if you decide one month you want to watch one of our webinars that's available on delivering immunizations or ordering immunizations for HIV-positive patients, they can then check that box. Okay. If they have a mentor that comes in, or a clinical consultant who comes in and gives them some guidance around this, I've actually done some remote, what we're calling distance mentoring, where I come on the phone and do cases with the care team around HIV management, and so that would be a box that they could check. And then if they applied that proficiency in clinic, they would check that box. And we ask that they keep track of this, but another option would be you could have like a centralized binder in the clinic, and just have everybody keep their monitoring framework there, so that they can, it's all in a central location.
In one location, right?
Exactly, and sometimes that's easier. We all print stuff and then it gets lost on our desk somewhere, and we find it a year later. So sometimes it's easier to keep it all in one place, but that's something you can discuss with the care team.
Okay.
And we talked a little bit about the virtual learning lab. We're going to go over a lot of that in much more detail when you all are here in April. And these are our contacts. Myself, I'm up there, and Mona Moore, who's a phenomenal physician assistant and HIV specialist, is also on our team here. Christine Stewart is our program manager, and then our project leads. And you can feel free to contact us anytime around anything regarding the project. Really briefly now, I just want to go over this last piece, and this will be, this is again, Dr. Fan, I will be sending you these self-assessments. This is sort of the next phase in the assessment process and these are geared towards your individual care team members. So what we do is we send these to you electronically, and we ask them that you pass it out to each one of the care team members that you think is going to participate in the training. And what this does is it really gives them an opportunity to go through each of the proficiencies and determine where their actual HIV training needs are. And I'll show you what they look like here, but first I just want to highlight a couple of things. It's really important that they fill it out completely, especially well, really all of the pages. But if they could put their contact information up top, including their specialty, because it's really important for us to know whether, we're training a pediatrician. Exactly. So if they're a pediatrician or an OBGYN or a women's health NP, that's important for us to know. And then also what site. I know you guys are growing like weeds, so what site they're going to be at, that will be important for us to know, and also their email address. Okay. Then we have some demographic data that is really important, because part of our mission is to train also minority providers in HIV care, and we're actually asked by our funders to get this information. So that's why we have some of this info up here on the self-assessment.
Okay.
So this is what the self-assessment actually looks like, and this is for provider stage 1. So here what this is really a list of both our foundations curriculum, because we do ask that the providers look through that to see if there's anything that they may need, and then also the actual provider curriculum. So what it does is it gives them we collect 2 pieces of information. The first one in column A is a method for the provider to rate their proficiency, rate their competency in each learning proficiency topic. So, for instance, I'm going to take, let's see, optimize clinic management to address health needs of HIV-positive patients. Well, you know, I'm a clinician. I don't really have an administrative role, so I would probably say that I am able to perform that proficiency, but with direct sort of HIV expert guidance around that area. So I would rate myself as a 2 there. And I would check in the box in column B that I would like to include that in my training plan, because I want to learn more about that and maybe get up to a level 3 or maybe even a level 4 with the training. So really what this does is it gives us an opportunity at the end, when you have them all fill it out and send it back to us, it gives us an opportunity to collate all the data that we collect here and say, well, it looks like, based on these self-assessments, that 90% of your providers once rated themselves as a 1 around identifying need for and readiness to begin antiretroviral therapy. And 97% of them or 98% of them said that they wanted that in their training package. So we would then tailor our training or guide you as you tailor the training to say that, well, we think, you know, we recommend that you watch one of our webinars on identifying need for and readiness to begin ARV training or treatment as one of your group training topics. So it really helps us kind of hone in on what the needs are. Yeah, and it really helps also the providers see what the needs are. I remember you said Dr. Dow, is it?
Right.
Who may have some background, you know, who has some background in HIV treatment. So he may say, well, actually, you know, I already know how to order and interpret a genotype test, or I already know how to do OI prophylaxis. So I put a 4 there, and I don't want it in my training plan. But he can use this form to keep track that, you know, he said, oh, well, actually, you know, I do need some review on managing ARV drug-drug interactions. So it kind of acts like a tool for us and a tool for the user as well to keep track. And then there's some questions at the end that are related to how they prefer to receive their training, whether or not they've had any mentorship or experienced any barriers to training. And that's it. So, and I will also send you a couple of extra little tips on how to facilitate your providers in filling this out. But pretty much from our clinical training standpoint, that's about it. Do we have any questions about anything before we move on to the practice transformation piece?
Yeah, I have one question about that self-assessment that you just talked about. Is there a deadline that you would like for me to have them all back to you by?
Well, I will send them out to you today, and if possible, we're trying to have them back by late next week. This is so that our project coordinators can get all of the data inputted and so that we could have it ready for you when you come in April, or, well, it is April now, in 2 weeks, I should say. But we know that it's really difficult sometimes, and, you know, providers can be tough to get a hold of, and they're not in the clinic every day probably, or they may be at different sites. So that's, we're asking for late next week, but totally understandable, and if by any chance you can't get them all to us, we ask that you try to bring them to the community meeting when you come down. Yeah, and then we can, kind of do a quick overview and take a look and do a quick assessment.
Okay. Thank you.
Okay. And we do prefer that you send them back electronically, but if you have any trouble, just let me know. And we've had some clinics send or FedEx, and we'll pick it up, or fax their forms to us.
Okay.
Okay.
Thank you.
Sure. Thank you. Anyone else have any questions?
We're good.
Okay. Great. All right, so I think I'm going to go ahead and turn it over to Mazdak and Sarah at PCDC, and I thank you all for participating and look forward to meeting you in April.
Same here.
Or I keep saying in April like it's January. In 2 weeks.
In 2 weeks.
In 2 weeks.
It is around the corner.
I know. I can't believe it. Okay, thank you guys.
You're welcome.
Javier, would you mind giving me the ability to scroll, or can you scroll as I talk, or what would be the best?
Okay, that requires a lot of knowledge of technology on my part, but let me.
Do you mind just scrolling if as I'm talking and?
Yeah, actually, let me just run and grab Jarrett so that he can give you full. Actually, Andrea's coming to my rescue right now. I'm like frozen in front of the screen. There you go.
Okay, so I just want to say hello to Dr. Ansari. I know that you came in, you were running from something else. I really appreciate that you were here for this, and that we're really looking forward to working with you all to, give you the performance improvement piece that will make all of the clinical pieces work better. So the first thing we're going to talk through is revenue maximization, and I know that there's a few things that we're not completely filled out, so we're kind of just going to do this together and just, talk it through. So I think I'll just go ahead and begin. I don't have the ability to scroll right yet, but we can just go ahead and start talking. So the first piece is revenue maximization, and I saw that the breakdown in terms of how patients, in terms of how reimbursement happens at your center it looks like, and I took this from the application that you submitted, so it looks like there's about 59% on Medicaid, 20% uninsured, 7% on Medicare, and 13% private. That's kind of what I just saw from those numbers. Do you think that, in terms of your Medicaid population, do you think that most of your patients who are eligible for Medicaid are getting enrolled into Medicaid? Are they actually, are you seeing any gaps between eligibility and people who are actually getting onto Medicaid?
Not really. What we try to do is, like everyone else, is all our uninsured, we try to get them enrolled somewhere.
Yeah.
So, that the self-pay is really what we're trying to do, which is where we put our uninsured. So they sort of sit in that pot until we get them insurance.
Right. And in terms of the self-pay, are they offered a sliding scale? How does that work at your?
Yeah.
Okay.
Yeah.
And do you usually get some kind of payment from your self-pay patients, or?
Not much. No.
Right. Yeah, that is a challenge for everyone. So in terms of your self-pay patients, is that an area where you would like to have more support around trying to figure out how to increase, any potential revenue?
Yes.
Okay, because that's something that we can definitely work with you on. We've got some strategies for that. So I'm going to put that down as an area to focus on. And it sounds like most of your patients who are eligible for Medicaid are able to get onto Medicaid. They just have to go through that enrollment process.
Yes.
Okay. So right now, it sounds like your, in terms of the rejected healthcare claims, there isn't that much information being collected on rejected claims. Is that correct?
Not right now. We just started with a new EMR system.
Uh-huh.
So with that new system, then we'll be able to pull that data and start collecting it.
Okay. Were you able to collect that data before the EMR?
No.
Okay.
Well, yes and no. Part of it is that just getting the staff to actually code it is one thing.
Uh-huh. Right.
That's different from being able to collect it. They have to put it in to do it. So just getting us in the habit of learning how to bill for HIV will help us get the data.
Okay. And I know that EMR is a relatively new. This is new, right? When did your EMR system start?
Well, we just went live Monday, but we
wow.
already had EMR, so that's not new to them.
Right. Okay. But right now there's a need to kind of make sure that the staff are coding properly with the new system, and specifically around HIV services.
And we did build an HIV template in there with the code.
Oh, great. Okay. Okay. So the template's in there. It's just a matter of getting everyone's mind around how to use it.
Yes.
Okay. Okay. And in terms of healthcare claims and tracking that, do you feel like it's just a matter of putting the EMR into play? I mean, do you think you're going to need some more support around making sure that actually really works with tracking your healthcare claims and knowing how many are being rejected? Is that just a matter of, kind of catching up to the technology?
Yeah, it's really just us knowing what we're looking for, because we can pull it once we know. So if we're putting in claims, then we should be able to pull we should be able to see how many have been denied.
Okay.
We just haven't been doing that practice, actually.
Yeah. And once you know that they are denied, do you have staff who are, assigned to get on that?
Yes.
Yes, I'm sure you do. Okay. So let's see. Just moving along here. I don't know if I have. I'm going to go back to my screen here and see if I can scroll. I guess I'm not able to scroll yet.
Hey, Sarah.
Yeah.
For some reason, I'm sorry to interrupt. We're having some difficulty switching over to you, but we actually were able to give Mazdak the control, so he should be able to scroll if he can.
Okay, Mazdak, do you?
I just moved it to the next page. Could everybody see that?
No, I'm still on the revenue maximization page. The first page.
Is it the second page? Oh.
What are you all seeing?
We're seeing the maximization page.
Revenue maximization page.
Okay.
Okay. Oh.
Yeah, I tried to switch it to.
Yay!
I think I clicked it back. Can you see it now? What are you seeing now?
Performance improvement assessment.
Okay.
Did it move now?
No.
Revenue maximization is still showing.
Yeah.
No. Okay. Would you all mind, just to save time, Stefan, to scroll to the next page for us?
You just scroll to page 15.
Sure.
Great. I appreciate that. This is where we are right now in terms of the conversation. Appreciate that. Okay. So moving along to 23. Does your health center currently have a process to ensure that patient encounters are coded in such a way to maximize reimbursement? That's kind of what we were just talking about. And it sounds like you do have a process. It's just that you're making a transition to a new system. And I was wondering if you're familiar at all with the relative value unit, the RVUs for patients living with HIV/AIDS in your coding system.
Yeah, we're familiar with it.
Mm-hmm.
We haven't obviously used it though because it's a new system. So.
Right.
But we are familiar with it, and we haven't really, as an operation, really dealt with RVUs. we've tested it, but we do know what they are. We have done it.
Right. Okay. All right. So maybe more on that later.
Yeah.
Okay. So in terms of, just the steps involved in billing, when a patient, comes to your center, and then when, all the things that kind of happen until you get reimbursement, can you, I know that's probably a long process, but I'm wondering if there's just a way for you to just break it down for me really simply in terms of what happens with billing.
Pretty much, actually, now that we're going electronic, the registration gets the patient in, the provider sees them, they code the note, send it straight to billing, billing reviews the claim, and it's out.
Uh-huh. Okay. And then you're going to be getting some kind of claim report.
Yes.
Through the EMR system,
yes.
Okay. Okay, great. Is this, besides the things we're talking about with coding, is there anything that you're thinking of specifically that you would like some support around, any kind of area of improvement or, concern now that you are using a new system?
You know what we would need help in is just really processing a claim, particularly for HIV, because we really don't do it well.
Okay.
We really, because if we're dealing with the primary care aspect and we tested them, we need to make sure that the staff is actually including that testing code with the primary care visit.
Right, right.
Or if we're doing women's health and you come in with an STD and we test you with HIV, how do they? I need to understand more how the staff does that. Because a lot of times in the past we've just forgot. We might have tested the HIV for HIV, but we didn't put it in coding. We just actually handled the primary visit.
Yeah.
But if I tested you because you had an STD, I might not have put in that I actually gave you an HIV test.
Right, right. And especially in terms of the billing section of the EMR, it may be in the clinical progress note, but it might not be where it needs to be for billing purposes.
Yeah.
Okay. Okay, got it.
Does that make sense?
Yeah, that makes perfect sense. So we can definitely put that in. All this is, this assessment that we're doing right now, all of this is going to go into a project plan. And so we're going to be breaking this down into real goals and activities, and I will review that with you all later. But this will give us, this is kind of giving us all the information we need to really put it into concrete goals. So yeah, that makes perfect sense. Okay, so then we're going to move on to quality. Unless, Mazak, do you have any other questions you wanted to follow up with in this area?
No, I think you've covered it great. Thanks, Sarah.
Okay, good. So on to you for quality improvement.
Okay, I think I am the presenter now. So did that move for everyone to quality improvement?
Yes.
Mm-hmm.
Yay. Thanks. So I'm just going to go through generally these questions around the quality improvement process. What kind of quality improvement process do you all currently have? Do you have a committee?
Yes.
That meets?
What we have is it meets monthly with the medical director, and how it functions is that we have just like everywhere else, you would have a specific thing that we're actually auditing or looking for quality improvement. So, for instance, say we go if we want to use measuring how many tests we do a month for HIV. That would be something that we would try to quality improve. If we're saying we want to do 200 and we're only doing 190, we can actually test that.
Okay, and so, that's something it sounds like you've already done around testing through the screening initiative?
Actually, we haven't. We just keep up with it monthly, but it might be something we want to do for HIV, for quality improvement, to ensure that we are testing, and particularly we testing at particular sites.
Okay, so we can definitely write that in, and what we're probably going to do is use whatever the clinical measures are that come out of the clinical component of this, and then we can use the quality improvement structure to track whatever you all decide are your goals, ultimately. So given that, can you tell me a little bit about how your QI committee is functioning, what you think they do really well, and if there are any areas that you think you might be struggling with and need some support around?
Because we're just really beginning to work in HIV, I really want to see if we can get the providers to really focus on actually looking at it as a quality improvement goal. We do diabetes, we do hypertension, but HIV is not one of them.
Great. So around just incorporating some of those clinical goals into your existing quality improvement structure.
Yes, because we want to make sure that we're integrating the testing in our regular, normal operations of giving primary care services.
Great. Okay, and you mentioned the Quality Improvement Committee meets monthly.
It meets monthly.
Who plans and executes the projects?
The medical director, along with, we have one of our assistants that she does an excellent job at collecting the data for us and doing the analysis.
Okay, and one of the things we're looking at right now is, in addition to a lot of health centers do have, obviously, that's the Quality Improvement Committee that's functioning well. What is more rare for health centers is to have this culture of innovation and learning and quality improvement that's spread throughout the health center. So it's not just held in the hands of a few people, but that everybody understands who's part of the clinic what the QI projects are and what their role is in those projects. And so I'm wondering, is that something you all feel like you already do a good job with, or that you'd like some more support around?
We would need more support around, because what we do have every month is where the whole staff meets once a month. So, I mean, the entire operation meets, all the employees meet once a month. So it's something that we can do in that meeting.
Okay. Great. So that's something that we can work on if you all decide that that's a priority. And how does that Quality Improvement Committee come up with what its priorities are, what it wants to work on?
We work from our, what we call patient-centered medical home.
Okay.
Standards and HRSA.
Okay. And so you mentioned you do have a project around diabetes. Are there any other QI projects right now that you all are working on?
Yes, diabetes, hypertension, smoking cessation.
Okay. Great. And when so the QI committee shares what it's working on during those monthly meetings. Is there any other way that information about what happens in the QI committee gets shared with staff or patients or other organizations?
Not really. That's something we can think about.
Okay, great. And then would you mind, I didn't get this, but if you have minutes from your previous Quality Improvement Committee meetings, or so we can get an idea of how it functions and what you've worked on in the past, would you mind sending that to us?
Yes, I can send you a couple of samples of the last couple of ones.
That would be great. Thank you. So we've identified that really kind of that spreading the innovation of QI beyond just the Quality Improvement Committee throughout the whole health center, and then also really working to integrate those HIV-specific goals into the work of the Quality Improvement Committee in the same way that diabetes and hypertension is integrated. Aside from those two things, is there anything else that you would like support around quality improvement?
Nope, I just want to see if we can operationalize those two things.
Okay, great. And Sarah, is there anything?
Oh,
Yeah.
You read my mind. I was just looking through the application that you all submitted, and there were some notes about your clinic flow process and your referral process and how you wanted to work on that. And so I was just wondering if you could kind of explain, you know, maybe briefly what you were thinking about in terms of your clinic flow and referrals for HIV.
That's a good question. One of the things, it's really the follow-up for us. When we send our patients out to one of the hospitals that actually did the services for us, is really having a better communication with them as to what they've done with the patient and how do we actually complement what they've done.
Yep.
So it's really follow-up. Once we send our patients out, how do we actually continue keeping open communication with what they have on the HIV side versus with the primary care.
Great.
And I know that's something that we're working on with some other health centers. Or they put it in actually their reporting functions about how they can be better about tracking and reporting and closing the loop around referrals.
Yes.
So definitely, I don't think you guys will be the only ones working on that.
Right.
Okay.
Right. Sarah, anything else?
Yeah, and I had another question about, you'd mentioned also that there was a training in 2007 around HIV standards of practice with protocols and procedures, and that there's been some new staff, you know, in your sites now, and so you wanted to get some more training around this. Were you thinking about just kind of having the same kind of training that you had before in 2007, or was there something that you were thinking about specifically, you know, or something that you were thinking about differently with the standards of practice?
I think we had no 7, but in addition to some of this stuff, we're just talking about quality improvement and the follow-up, all the things that we're trying to improve need to be part of the training as well.
Yeah. So besides the standards of practice, it's also more kind of specific training around what happens at your particular practice. Is that right?
Because what happens, our staff will test. They know, you know, we may have HIV patients, and the primary care, but they really don't necessarily know what happens with us operationalizing it as far as reporting, the rest of it.
Yeah. Which really ties back into the culture of innovation that I think Mazak's talking about, which is when everyone knows everything.
Yes.
Great. Okay. So that was it for me.
Great. Thanks, Sarah. Anything from AETC?
No, I think we're good. I'm just trying to think. We'll probably need to do some next steps here. And
we're still actually. Oh, sorry, you're trying to figure out how much time we have.
Not done
we
yet.
Still have a lot more to go.
Okay. Sorry about that.
No problem.
No problem. Great, thanks. So moving on to the Plan, Do, Study, Act section, this is really, we're trying to figure out what sort of improvement methodology you use. So do you all use the Plan, Do, Study, Act improvement method currently?
Yes, we have, yep.
Okay, and how comfortable is your QI committee using that, and then also like the staff as a whole?
The QI doesn't use it as much as the staff as a whole when we're trying something new.
Okay. Is there any training or support specifically around PDSA that you think your health center could use?
We probably can use, because I have a whole new team now.
Okay.
New young providers that probably have no clue. I'm just going to be honest.
Okay. No, we love that. Please be honest. And definitely no judgment. I think it's very common when there's turnover, there's new folks on board, that everyone needs to be brought up to the same page. So we definitely have a little webinar or a training around PDSA, so can offer that to you all. And then this could also be part of that culture of innovation. So
that'd be great,
Great. Actually, this section is pretty small, so I think that's it that I have. Sarah, do you have anything around PDSA?
No, I'm good. Thank you.
Okay, you're welcome. Next, we have cultural competency, and I know you guys did a really good job of explaining how your staff really reflects the population that you serve, and I think that that's such an important part of cultural competency. I'm wondering, aside from staffing, if there are any other if there's any other sorts of training or other sorts of methods that you use to ensure that the staff and the agency works with patients, specifically the patients most impacted by HIV and AIDS in their communities or folks with HIV/AIDS, how that is handled at your health center.
Honestly, the one thing I do like about the integrated model is that it's not stigmatized. So, our staff really doesn't treat anyone with HIV any differently than they treat any other patient.
That's great.
So,
I know. That's really great. It doesn't happen everywhere. So, one thing that some other health centers have faced is that sometimes they have providers who may not be comfortable asking sexual health questions to all the populations they serve, or behavioral, or questions about behaviors that may lead to HIV infection. Is that something that you all face?
Yeah, that would be bad.
Sure.
I think that would be great.
Was that okay?
Yeah,
so
I think that's an issue.
That.
Yeah, give us some support.
Yeah, that would be great. It's not just here in Buffalo, but my Niagara Falls sites where they really don't have a lot of HIV testing or information about it at all.
Okay, great. So that can be an area that we work on. And then one of the unique mixes that you all have, you mentioned that it's not just African American, but it's Black, and there are folks immigrants from sub-Saharan Africa as well as African American populations. And I know in other parts of the country, the risk behaviors are really different in who's getting infected from sub-Saharan Africa versus African American. Is that something that your staff could use a little bit more training or information about?
Absolutely.
Okay. Great. And then in terms of measuring cultural competencies, does your health center measure that at all, either through provider comfort questionnaires about how comfortable a provider is in giving services to certain populations, and also in terms of patient feedback about how comfortable they feel working with their practitioners around certain issues?
We actually do regular surveys for the patients on how they feel about us, but we don't do it with the providers. So that's something we can use some help in with their comfort.
Great. And does the patient feedback survey, does it explicitly talk about cultural competency or something that gets at that?
Not necessarily. The format that we use is based on our patients in a medical home, their standard their format, but it's not something we can't put in there.
Okay, so we can think about maybe adding some questions.
Yeah.
Great. Are there any other challenges that you think your health center faces regarding cultural competency for the populations that are most impacted by HIV/AIDS in your community?
No, just getting educated.
Okay.
Sorry, what was that?
So,
just becoming more educated.
Okay.
Thank you. So if we covered the priorities that I pulled out from our conversation is some of the training around increasing provider comfort, around asking questions around behaviors that may lead to HIV, including sexual health questions and intravenous drug use questions, maybe some training around the nuances between risk factors or the trends in folks from like sub-Saharan Africa who are immigrants versus African American populations and any other populations that you may see the greatest incidence in your communities. And then also including questions both around provider comfort and around patient feedback around how they feel that the health center's cultural competency is going. Does that cover it?
Yes.
Mm-hmm.
Okay. Anything else you all would like to add for that section?
Nope.
Okay. Sarah, anything you would like to add for that section?
Nope, I think we're good.
Good. And then I think this is you, Sarah, correct?
Yeah, I think so. Okay.
Okay.
So now we're going to move on to recruitment and retention. Let's see if that's up there now. Let's see. Okay. And with the recruitment and retention, it really sounds like you all undertook an incredible, you undertook an incredible outreach initiative with, moving from 5 tests to 500. I think I wrote down some numbers. I hope I got them right. But I heard that you were doing social marketing and putting outreach folks in communities that are really at most risk. And so I wanted to hear, since you did all that work, where do you think you are now in terms of reaching out to people who are at risk? What lessons did you learn? What would you like to do differently at this point?
I think we need to really have more of a systematic way of outreaching, because now we're in 2 counties.
Right. So you're covering a larger geographical distance.
Yes.
Right.
Yes.
And how many folks do you have available to do outreach in your staff right now?
We have about 4.
Okay. And are they called outreach workers? What is their title?
Yes. Yes.
Okay. All right. And do they have and how do they decide where to go and what to do and who to target?
What we do, this is Beverly. Dr. Ansari had to step out for a minute.
Oh,
what
sure.
we do is we send out people based on events, a lot of them. So we are partnered with Block Club, the local colleges and universities. We're also partnered with area churches, community centers, any place where people will gather, all places where people will have an event that we can speak to HIV. We come to those events. We put information out. What we do is we tell people what services we provide, and we also we let them know that we do HIV test everybody, why we are testing everybody, why is it important that we're doing integrated testing, and we invite them to the center and actually to have that test and to receive other medical services. So we don't put HIV out so much in the forefront. We just say, yes, we provide services, we provide dental services as well as this as well. So right now, that's the current plan that we're using, because we're partnered with in the Buffalo area, over 45 community agencies. So we're able to do a lot of outreach with those folks.
Yeah, and I just want to add to what Beverly has already said. One thing that we've really focused on, I guess in the last year, is building a really strong collaborative network with HIV service providers in the area. And so what we do is, in collaboration, we'll come together and we'll do, like, for example, back in December, this past December, we did a World AIDS Day soiree where we had Cheryl Lee Ralph come in as the guest speaker. You all know Cheryl Lee Ralph, the actress and singer?
Yes.
I do. I've heard her speak a
lot.
Yes,
it was a
she's
fun.
Great.
Oh, yeah, she's awesome. It was a phenomenal event.
Wow.
The Community Health Center was the anchoring organization that took the lead. And, we're going to continue to do things like that in addition to what Beverly has described.
Right. Great. But it sounds like you probably are also, you've got a certain amount of resources with your workers and they're covering a lot of ground, so we need to figure out a way to use them more strategically perhaps. And I'm wondering too, let's see, in terms of your outreach and education, see, I'm kind of just moving along here. I wanted to take a step back and just and talk more about how you recruit patients on site for HIV screening and for HIV screening. Do you all do you do opt-out? So the patients offer the HIV test as part of routine care, and then they you know sign a piece of paper if they actually do not want to get tested.
No.
Okay.
I don't know. I don't believe we do an opt-out.
No.
I do know we do
it's voluntary testing altogether.
Right.
Okay. But it's voluntary, so they're offered HIV testing, and then they sign a consent form from the DOH, from the New York State Department of Health.
Right.
Yeah.
Okay. Okay. Would you all like to move towards an actually? You know, New York State. Every state's a little bit different. So New York State, yeah. Okay. I'm just thinking about my state-by-state laws here. In New York State, no one really does opt out. It's a different kind of combination. Yeah. Okay.
Mm-hmm.
All right. So I guess. So going back to your outreach towards the external community, what do you think are some of the main barriers for clients that you see at the health fairs or see in the communities? What do you think are the barriers in terms of getting them to your centers? Do you feel like there's usually a pretty good continuum between the people you see out there in the community and having them come back in, or what are the barriers that those clients might experience?
Some of the barriers for at least Western New York and Niagara County, one is transportation. Although we're centrally located, literally we're right in between, in Buffalo we're in between two train stations, so they're within a block each way. But in Niagara County, we're located close to one of the medical centers, so we're still accessible to the population that we need to get to, but people also always seem to bring up, well, transportation is an issue for me. And the further we move out to the east end of the county, transportation is limited in the east end of the county. There's not a lot of public transportation. There are definitely cabs and things like that, but there's not public transportation. It's not a lot of it. So sometimes I think a barrier could be transportation.
Right.
And sometimes it's just the follow-through. It's the follow-up.
And I think
and what we've done is now we're scheduling appointments on site. So if we go to an event and we use services and people say, well, I would really like to come, we try to make them an appointment at that event as opposed to having them call us.
Right. And I think indirectly what still are barriers are like, a lot of apathy in the community still. A lot of people are really convinced still that there's a cure for HIV and AIDS, and so, it's not a big deal if you get infected, and so no. But a lot of denial too. We've had patients who, they knew they were infected for 10 years and were not in on any kind of treatment or care, and then they would come to the community health center for a test, not telling us that they were positive for the last 10 years. And then when the positive test result comes back, or, they break out crying and, oh my God, how could this happen to me? And then we find out later that they've known for 10 years that they've been infected. And stigma, Buffalo has a large faith-based community, and there's still a lot of stigma about, HIV and AIDS and admitting that you may have been exposed or that you may actually be infected, and afraid to come to a community health center where they may know a lot of people there who work there, or may run into fellow friends who are also there getting some kind of care. So it's just, I still think that's still a big barrier besides, the actual direct barriers like transportation or, lack of insurance. We're still trying to educate the community that you can come to a community health center, especially if you don't have insurance. Like, we're still trying to let people know what we do and who we are. So insurance or lack of insurance is still another barrier that we're trying to overcome.
Okay. Thank you. Yes, it sounds like there's a lot of, so there's logistical barriers for patients, but also kind of, you know, philosophical, ideological barriers as well.
Psychosocial barriers, right.
Right, right.
Yeah.
Okay. And so I think maybe what we could work on, you know, in terms of system goals is messaging and how to address those in terms of the right messages to use with people to kind of get them, you know, to maybe grapple with their stigma in a different way or their feelings about it in a different way, and then
Sure.
coming up with a more strategic assessment tool for your outreach workers so they can kind of know where to put more of their energy to really reach the people you're trying to reach. Was there anything, Mazak, that you'd like to ask at this point?
Yeah, I mean, I think, I mean, it sounds like you are in a place where recruitment would be the place to focus, but I know that once the recruitment happens, where some health centers have trouble is retaining people within care. And I'm wondering if overall, or even specifically with HIV-positive patients, if what your strategies are to keep people in care.
I think the biggest issue that we've faced in terms of retaining our HIV-positive patients is really a medical provider issue, because a lot of the patients actually, once they come to us, they want to stay with the community health center for their HIV management. But because our providers are not comfortable with managing HIV, the providers will send the patients to ECMC or some other external comprehensive center for care. So I think that if we can give our providers the knowledge that they need and empower them with the confidence that, listen, you can take care of HIV-positive patients in a primary care setting, I think that'll help us to retain patients, because the demand is there. The demand is certainly there from the patients. They want to stay with the community health center for their HIV care. I mean, we encourage them to stay with us for the primary care part, but they also want to stay with us for the HIV part as well.
That makes a lot of sense. I think then we can start that as an initial goal. And then maybe as you all start seeing more HIV-positive folks for to manage their disease, that we can take a closer look at the retention of those populations.
Great. Okay.
Oh,
Thank
but
you.
I have to add one last thing. Of course,
yeah.
You know, one of the with the few patients that we do have, the 3+ patients that we have, with the population we serve, adherence to treatment and dropping out of care is an issue that you know everybody is facing across the country. So I suspect that we would have that same issue too in terms of retention, where patients are dropping out of care because of poor follow-up and adherence.
Okay, so potentially getting more support around best practices around retaining HIV positive. Okay. Great.
Okay. Thank you.
Are you ready for me to move to the next page, Sarah?
Sure. Okay. So now we move on to access, you know, just speaking specifically about appointments. So what does it look like right now in terms of appointment access for you all? Do you use open access? Do you handle walk-in patients regularly? You know, can you talk a little bit more about how you handle your patients coming in off the street?
Yes. We do walk-ins. We schedule people. We do routine scheduling. We do walk-ins, and we do continued appointments as well, meaning when they've seen either social work or if they've already seen a provider or dental, we do follow-up appointments with them. If it's a person who has been HIV positive, what we try to do, if they are positive, we send them out, of course, for their confirmatory test. We refer them to ECMC, like Dr. Fan indicated, and then we also try to follow up with them again after the week after they should have scheduled that appointment, seen that provider at ECMC, and then we continue to link them into all of their primary care and their dental services as well.
Okay. And
I'm sorry. Say that again,
Did
Beverly.
Did I forget anything, Dr.
No,
Fan?
no. One other thing, though, is that we do have, and I don't know if you guys are interested in this, but we have a newly appointed access coordinator / manager who is
great.
helping. Yeah, Kevin Glover, right, Beverly?
Yes.
Who is helping us to ensure access to all of our patients, including the HIV, patients that are interested in HIV services. So.
Great. That's amazing. So, and in terms of your walk-in patients, what's an estimate, would you say, as to how long it takes them to see, either a triage nurse or ultimately the provider?
How long does it take them to see?
How long does it take them to see the? Yeah, sure. I'm sorry. How long would it take a walk-in patient to see the provider?
Depending on how busy the flow is. 40 an hour.
Okay. And for a
wherever
patient,
you can fit that person in at.
Right. And in terms of a patient who's got an appointment, how long would it take them to see the provider?
30 minutes.
Okay. Do you currently track your cycle times regularly, or are there certain measures you use to figure out your, how well your patients are getting to you and getting to see the provider?
I think we are starting to track. We have what's called the dashboard, so we can see who's where patients are going, and we can see the flow. With this new facility, I think we now have, it's 22 rooms, Dr. Fan?
Yes.
It's either 20 or 22.
You have 22 rooms.
22 rooms. And all of our rooms are set up in a strategic plan. They're called pods, and I believe there are 4 rooms per section, and each section has a nursing station. And we have a ped pod, and then we have a family medicine pod, and in between are the 2 general medicine kinds of pods. But this dashboard allows us to see if there's a provider who is not working with someone, and we have a heavy flow of patients, and those patients can be flowed into various offices. A provider can be floated to meet the needs of whatever pod that person would be in.
Great. So with your new EMR system, things are opening up in terms of how you're able to see things.
Exactly.
And have you kind of undertaken, previous kind of performance improvement, initiatives around appointment access? Have you tried to work on your cycle times at other points in your, in the lifespan of the practice? Have these?
Yes, they have.
Yeah. Great. And it's just in general, is this an area that you think you would need more support around, or are there specific things that that are just sticking points that you're just not able to figure out or, improve in this area?
I think that, sure, there's always room for improvement because that is a big issue with patients, no matter where the practice is. They want to be in and out. And so flow is always a constant thing that we need to improve upon. So, sure, we could use additional support in that area.
And I know that before, I mentioned this before a little bit, but there's the flow aspect to an HIV test and, education and getting results. Do you feel like that particular flow needs some particular attention or still at this point, or is that pretty well organized?
Beverly, what do you think?
I think it's pretty well organized. I think there's always need for improvement, though.
Yeah.
I think that, the better and more proficient we become, the better our services are in terms of all the patients. A new patient takes a little bit more time, but, I think every process can be fine-tuned.
Right.
Every process.
Right. Okay, great. So, I mean, I guess what I'm hearing here is just kind of making sure that you all know about best practice kind of strategies for access, for appointments and open access, and then seeing where it could fit into what's going on now with your new EMR system and with your protocol, with your flow protocol. Matt, Zach, anything to chime in here?
No, I think that was great.
Okay. Okay, so, and again, this is going to be working to a project plan that we'll all be able to take a look at together, and so if anything else comes up later, we can always, put it in later. Okay. But that's the general gist. Okay, so the last piece, I believe, is reporting and population management. And so with that, I know that you have an EMR, which is great. And is it eClinicalWorks? Is it ECW?
ECW?
Yeah.
Yeah. I just got tired. Yep, it's ECW.
ECW.
Okay, perfect. And since you're just getting just becoming familiar with ECW, maybe the reporting piece is a little bit, it may be a little bit difficult to complete. But are you familiar right now with how to request custom reports out of ECW? Have you been able to see any reports coming out of that system so far?
The system just went live but prior to us going live with this system, we were doing MediNotes.
I'm sorry, I'm so sorry. Could you repeat that, please?
Prior to us going live with ECW this week, prior to that, we were using something called MediNotes.
Okay.
Where so in MediNotes, we could gather and pull data. But now with this EMR system, it says with ECW that we'll be more efficient in terms of being able to go in and pull data. There are things that have already been flagged, that things we know we need to pull, that we need to pay attention to. So done it yet, but I believe that there has been some test runs on that stuff so that we will be able to get some results at the end of the day. We could go in and pull how many HIV tests were done, how many tests were positive, did we refer out, who did we refer to? So all of the mechanisms have been built into there.
Right, right. And who reviews your reports? I guess when you were using MediNotes in the past, how was that done in terms of, how often you pulled reports, the kinds of reports? Who kind of managed that information for you?
Our IT department, and we also have a system, a program. Kyle Morgan's title, Dr. Fan, I think he's a program
analyst.
Yeah, program analyst. He pulls the reports, and and we have weekly. Right now, we're having weekly, but we have week managers meetings where those reports are reviewed with Dr. Ansari.
Oh, great. Okay, so weekly meetings where you all review this list of reports that you all. Okay, great. And is there currently an HIV data report in there?
Yes.
Okay.
I'll review that report. Yes.
Okay. Now, with your previous system, were you all able to do cohort reports or panel reports? And and by that I would just looking at a very specific, like let's say patients who began getting services from you in June of 2011 and seeing where they're at now.
I think they had the capability to do that. Whether they were doing it, I don't know. Beverly, do you know if they were actually following patients for outcomes, to see health outcomes?
I don't know. I think at some point we were following them, but I think some of it has sort of fell off towards the end there before I came aboard. So I can see how some of those things were being tracked, but then I see for a period that they stopped. Before we said, okay, what happened in this period of time, so that we can pick that once I came aboard in order to do that.
Okay. So planner reports have been used, but maybe they've dropped off because of, you know, maybe competing initiatives and different things.
Mm-hmm.
Okay.
Exactly.
So it was a competition about what to look at. Okay. Now, do you currently, were you using a registry before, or, you know, is the idea of using a registry for population management, has that been something that your practice has done on a regular basis?
Yeah.
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 Okay. Because right now, would you be, I guess, and again, you're just moving into EMR, into the ECW world, so, you know, I guess the goal is to really be able to pull a registry report that shows you the status of your HIV patients. You know, especially, of course, if you're moving into the treatment world, and but you know, the idea is that you'd be able to pull a registry that would show you different kinds of degrees, so a diagnosis code, a date of last visit, test results, did they make it to their appointment at an external agency, you know, so is that something you have done or would like more support around in the future?
Yeah, I think we need
more
support.
Okay.
Definitely more support.
Great. So that's what we're going to be doing. And then a lot of people need support around that, I think. I mean, you're providing services. It's hard to take a step back and pull these things and look at them and make sure that everything's correct. So we're going to try and really break that down so it becomes an easy part of your day-to-day. And I think the other questions are really around registries in general, so I think I'm going to skip over those and just say, so when you have your QI committee, I know that you have the weekly meetings to review the data reports that that you've kind of chosen to compile. Does the QI committee review those reports too?
I don't know, because I have not met with the QI committee yet.
Okay. Okay.
I don't, and I haven't actually been here that long, so I haven't met with them yet. So it could be that they have had a meeting, but I know who the person who is running the QI, and I can speak to her. I meet with her on other things, but QI just wasn't one of them.
Okay. All right. Because it sounds like probably when we start working on these reports, it'll be great to have that weekly check, on a regular basis and on a kind of a short-term basis to make sure that everything's correct, and then to really give that back to the QI committee to make population kind of longer-term decisions on how to use that information.
Right.
Okay. So that, I believe, is it for my piece. Mazak, did you have anything else you wanted to add?
I think that's good for now. We're actually running a little bit late on time, and we're just going to use this information, as Sarah said, to take a first pass on developing a project plan, which we're going to share with you. And there's still definitely opportunity to add stuff, but also I know sometimes folks are a little bit overwhelmed about all the areas that we covered, and I just want to point out that we're going to spend time prioritizing what you think is the most important stuff to cover within the next 9 months. So it's not like everything we talked about we're expecting you all to work on between now and December. So.
Okay. Thank you. That's
reassuring.
Yes, it really is. I'm like, oh my God.
But I mean, we're hoping to write this stuff.
I'm trying to get through this report as quickly as I can, and I'm like, but.
Yeah, no, we definitely get that, but we're hoping that you'll, then when you're done with what you set up between now and December, you'll have a plan for what to do after that based on these priorities that we talked about. So.
Okay, great.
Everybody take a deep breath.
But we really are excited about you guys helping us go to the next level, and so thank you in advance for everything.
Oh, it's our pleasure.
And now I'm going to hand it back to Steph.
What did Javier say?
I think so.
This is Jared again. Thank you, Mazak. And just to wrap up, can you all see the next steps slide now?
No.
No, okay.
I'm on contact.
Yeah.
I think I'm still the presenter. Where is the next step slide so I can show it?
That would be,
What tab?
it should be, let's see. It's under the Buffalo PowerPoint. It should be the tab on the very right-hand side.
I don't have that tab, unfortunately.
Okay. Well, we will, I'll just read from it. So
Great.
the next steps are we'll be assigning you a coordinator from the AETC. In addition, we'll assign a clinical coach and a performance improvement coach, and together these 3 AETC staff members will assist you in all of your training needs. The clinical coach will work with the clinical learning leader to complete the self-assessments and then begin assessment-based training plan development. And as I'm sure Mazdak has mentioned, the performance improvement coach will be working with you to
Do you want us to cover that section, Jarrett?
Sure. I was just,
okay.
Yeah.
Sure. So we're going to be working with you within the next couple of weeks to schedule a time. Based on the information you provided with us today, we're going to put together a project plan, a draft project plan with these goals that we talked about, and then we're just going to check with you to see if they match with what you're thinking. And then during our face-to-face meeting, which is happening in a couple of weeks, we'll get the chance to really drill down and turn those objectives into like a 6-week implementation plan, so we can take that first chunk and decide how we want to tackle it when you guys head back after our time together in DC. And we'll also, at that point, you'll get to meet face-to-face all of the coaches, and we're going to do our best to have the coach that's assigned to you in terms of performance improvement to be someone that you've interacted with over the course of these calls. So please feel free to contact us if you have any questions. And Sarah, did you have anything to add about the process?
No, that's it. We'll just be in touch very soon with, with a time to review the project plan, and we'll send it to you a few days in advance so you can take a look at it.
Okay.
Great. Thanks, Mazdak.
Oh, hi. Hey, everybody. It's Stefan again. I just wanted to, in terms of the next steps, just remind Dr. Fan that I will be sending you the self-assessments, and if you have any questions at all, just feel free to send me an email or give me a call, okay?
Okay, let me make sure that you have the correct email address.
Oh, okay, great.
You have a pen and paper?
Yeah, go for it.
Okay, it's Fan, F as in Frank, ANN, medical @hotmail.com. So fanmedical@hotmail.com.
Great. And we've, just really quickly, we've been having a little bit of issue with compatibility with some of the Word versions. Do you know by any chance what Word version you use at the Health Center, or you have available on the computers there?
7.
Yeah, it's 2007.
Okay, yeah. Fantastic. We'll send you that version then.
Okay.
Great.
Thanks. So, Stefan, are you the designated clinical specialist coach?
I think we're still we have 2 here right now. So I'm on the call today. But we'll be assigning officially probably closer to the community meeting. But you'll get a chance to meet both of us, myself and Mona Moore, at the community meeting.
Okay, great. Look forward to it.
Likewise. Thank you very much, everybody.
Great, thank you. And just one more note is to ask you if you had any questions about the community meeting, travel or hotel.
No, I think all of our plans, they've made our plans already.
Yeah, our plans have been made.
Great. Oh, that's good to hear. And great. Well, we are excited about seeing you and getting started on the project. So thank you so much for being on the call with us today, and I hope you have a great rest of the day.
Thank you. Hope you have a good day, too.
Thank you.
Take care. Bye-bye.
Everybody.
Bye.
Bye-bye.